Good morning, everybody. Nice to be back. And this is the third and final day of the pre-licensing that we're having this year. Of course, we have the main conference that's going to be starting right away tomorrow through next Wednesday. So we'll continue to see you. Just a reminder, the link that you have should continue to work for that conference as well. My understanding is that you will continue to receive that link in case you have any questions, always reaching out to the conference email address for any tech support. And if during the session you have any questions, technical questions, using that live help button in the top right of your screen is the best way to go. I am hopping back on this morning just to let you know that, as always, if you've done this before, we do have an evaluation. We'll have an evaluation for these pre-licensed.
All right, sorry about that, little technical difficulty. So we have our evaluation survey that should be sent out with your email for the pre-licensing. And if it's not in your email, it will also be in the session information for today and then through the rest of the conference as well. So feedback on that would be super appreciated. So thank you for taking the time to do that. We will go ahead and move on to our last day of pre-licensing. As a reminder, please put all your questions in the live Q&A. Our slide decks are available after the conference ends. Amy and Shelley are back again from the Office of the Commissioner of Insurance and will be doing the first presentation on Health Insurance 101. So Amy and Shelley, if you want to go ahead whenever you're ready.
Good morning. As Elizabeth said, my name is Shelley. I'm with the Office of the Commissioner of Insurance, and our first presentation this morning is regarding Health Insurance 101. Next slide, please. OCI's mission has both a consumer component and a company component. In addition to helping consumers navigate the insurance marketplace, we also ensure companies are healthy from a financial perspective in terms of having reliably compliant business practices. This helps ensure that Wisconsin consumers continue to have plenty of dependable choices. Next slide, please. The first sighting of health insurance was in approximately 1929, when large industrial employers created access to health insurance for employees. Next, between 1950 and 1960, labor unions and more individuals began seeking out health insurance, typically creating a safety net for catastrophic health conditions. In 1965, the passage of Medicare and Medicaid resulted in one basic program of health insurance for persons aged 65 and older, and another program that provided health insurance for people with limited income funded by state and federal resources, respectively. And lastly, beginning in 1970s, the concept of managed care through health maintenance organizations was established. Next slide, please. The principles of insurance are risk and pooling. Risk in insurance is the uncertainty of a financial loss. One's risk tolerance is the amount of risk one is willing or wanting to take on by themselves or can afford to take on for themselves. Insurance is defined as a transference of risk. One pays the insurance company to take the financial risk from you to them for a fee, typically called a premium. And the more risk you transfer to an insurer, the higher the premium is for the product, as the potential for loss is greater. Applied to health insurance, The risk being transferred is the need for medical care during a year. The amount of coverage someone is willing to pay for through premiums may be affected not only by a general risk, but also for specific or anticipated risks, such as the need maybe for knee surgery or the planning of starting a family. Often, you will see lower premiums with group products. The reason for this is the law of large numbers or pooling of risks. Next slide, please. This is the insurance definition of the category in which health insurance falls within. The global classification of disability encompasses the list shown on this screen. These go beyond typical health insurance definitions. Next slide, please. Insurance law follows the state where the policy was purchased in. An exception, though, for example, is when an employer is, let's say, located in the state of Missouri, but has employees here in Wisconsin. There can be times where Wisconsin OCI would have jurisdiction over that health plan for those located here in the state. There would need to be at least 25% of the total number of employees residing here in Wisconsin in order for us to have that jurisdiction. Most disability policies offer a wide range of coverages and limits. The commissioner has the authority to regulate the terms of an insurance contract to protect the policyholder. The insurance laws establish statutory standards that are clear enough to protect the insured and also to give the commissioner the authority to set specific standards and provisions through the rulemaking powers. A group insurance policy is defined as a health benefit plan that is issued by an insurer to or through on behalf of a group that consists of at least two employees of that group, including at least two eligible employees. Under ERISA, which is the Federal Employee Retirement and Income Security Act of 1974, a group insurance plan is defined as an employee welfare plan to the extent that the plan provides medical, including
or as medical care to employees or their dependents, as defined under the terms of that welfare plan,
directly or through insurance, reimbursement, or otherwise. Lastly, a defined network plan is defined as a health benefit plan that requires an enrollee of that plan to use providers that are managed, owned, under contract with, or employed by the insurer offering the health benefit plan. Next slide, please. A healthcare plan means an insurance contract providing coverage for health insurance expenses. A comprehensive health insurance policy offers extensive coverage and acts as a financial pillow in case of medical emergencies. Unlike basic health insurance plans, a comprehensive policy covers outpatient as well as inpatient treatments, including consultations, medical tests, as well as hospital stays. Disease specific policies provide coverage and benefits only for specific causes of sickness, disease, or injury, such as a heart attack or a stroke, and often coverage is limited in amounts or limited in the amount of time. Next slide, please. The larger the group pool together, the greater ability to spread the risk. An insurer can spread its risk for high claims by collecting premiums from more people, which then reduces the insurer's risk and typically lowers the premium. Health insurance provided to employees by an employer is called a group health coverage, but health insurance you purchase on your own is called individual coverage. Small employer means, with respect to a calendar year and a plan year, an employer that employed on average at least but not more than 50 employees on business days during that preceding calendar year. The Small Business Health Options Program, or SHOP, Marketplace Plan helps small businesses provide health insurance coverage to their employees and is open to employers with 50 or fewer full-time employees. Large employer means in connection with a group health plan, and again with respect to a calendar and plan year, an employer who employed on average at least 51 employees on business days during that preceding calendar year. The 80/20 part of a health plan refers to coinsurance. Your insurance would pay for 80% of the total cost of the bill, and then in turn you would pay 20% of your total healthcare cost until you reach your maximum out-of-pocket limit. Managed care plans are a type of health insurance. They have contracts with healthcare providers and medical facilities to provide coverage for members at a reduced cost. These providers make up the plan's network. For example, a health maintenance organization, or HMO, usually only pays for care that occurs within that network. Some examples of federal programs are Medicare or Medicaid, and some state program examples are Badger Care, Care for Kids, and Forward Health. Next slide, please. A managed care plan is defined as any health benefit plan that requires or creates incentives for an enrollee to use providers that are owned, managed, or under contract with the insurer offering that health benefit plan. Wisconsin statutes define 3 different types of managed care plans. They are health maintenance organizations, preferred provider plans, and limited service health organizations. Next slide, please. With this slide simply put, when a consumer selects a plan with less choices for a network, the premium will be lower versus selecting a plan with more choices, which then in turn would mean more premium. Next slide, please. HMOs offer predictable cost sharing and administrative simplicity for patients. These features come with fairly restrictive rules about which providers patients may see. The Limited Service Health Organizations, or LSHOs, offer a limited range of services performed by providers selected by that organization. PPP or PPO plans provide more flexibility when picking a doctor or hospital. They also feature a network of providers, but there are fewer restrictions on seeing non-network providers. In addition, your PPO insurance will pay if you see a non-network provider, although it could be at a lower rate. And lastly, a point of service plan, or POS, is generally like an HMO. It requires the policyholder to choose an in-network primary care doctor and then to get a referral from that doctor if they would want the policy to cover a specialist service that would be deemed out of network. Next slide, please. This slide is purely a descriptive slide that shows again when a consumer chooses a plan with less network choices, the premium will be lower versus choosing a plan with more choices, which in turn would then mean more premium. Next slide, please. Another way insurers protect against risk is to narrow the coverage options they offer. This time, it can be through a specific type of care or treatment they will cover rather than coverage at a provider level. The ones listed on this slide are some examples of those types of plans. Next slide, please. Qualified health plans are comprehensive ACA compliant plans offered on and off the federal exchange. Medicare Supplement and Medicare Select policies provide coverage for some of the costs not covered by Medicare Part A and Medicare Part B, as we previously touched on yesterday. Long term
In general refers to a broad range of services you may need for an
extended period of time because of a chronic illness or disability. Long term care includes medical services such as nursing care or therapies. It can also include supportive services for activities of daily living called ADLs, such as bathing, getting dressed, getting in and out of bed, making sure you take your medications on time, and preparing meals. Coverage can be provided in a variety of settings that include nursing homes, your home, an adult daycare center, or a group living arrangement with supportive services. Lastly, we'll touch on short term policies here in just a moment. Next slide, please. These are some of the health plans that we touched on yesterday, which generally have exempt. Let me try that again. These are some of the health plans we talked about yesterday, which are usually exempt in general from our jurisdiction. Self-funded ERISA plans are typically large employers that are governed primarily by the U.S. Department of Labor. Labor, union, and employee welfare plans are also governed by the U.S. Department of Labor. Discount plans provide discounts on medical procedures with certain doctors or medical related costs, such as prescriptions, just like using a coupon at a store. These plans are not health insurance plans in the traditional sense. Medicare Advantage plans are the federal government's version of a Medicare HMO and replaces Part A and Part B. The feds and the Centers for Medicare and Medicaid Services directly contract with insurers to provide the Medicare benefits. Medicare Part D plans are the prescription drug plans that are sold separately from Medicare supplemental insurance or traditional A or B outpatient coverage by the federal government. Healthcare Sharing Ministries were one of the original versions of a GoFundMe account, and members share a common belief and provide funds to each other for their medical expenses. Lastly, direct primary care is reemerging from the past, with providers typically primary care internists or family practitioners negotiating directly with the customers. Next slide, please. Regarding short-term limited duration plans, some of the characteristics of these plans are: 1, they are not required to include specific ACA consumer protections. 2, some consumers may believe that ACA compliant plans offer and are priced to include unwanted benefits. Short term plans may offer premiums that are lower than unsubsidized premiums for ACA compliant policies, but they also expose enrolled and members to additional healthcare costs in the form of higher cost sharing and or non-covered services. Fourth, price sensitive customers lacking full information about ACA subsidies may gravitate towards enrolling in the low premium plans despite their limited coverage protections and high out of pocket costs. In many cases, short term plans may not be the lowest cost option. For the many consumers eligible for federal premium tax credits and cost sharing subsidies, ACA compliant premiums will be lower or comparable to these plans and offer additional benefits and less cost sharing potentially. Fifth, as stated, the loss of a short term plan does not trigger a special enrollment period option back to the marketplace. Sixth, these policies often are sold as a benefit of out of state association plans, and there are times when we have limited jurisdiction over them. And lastly, if OCI finds that an insurer or an agent represents a short term plan as compliant with the ACA or is providing more than a bridge to cover, is engaging in unfair marketing practices, and we will look at taking enforcement action. Next slide, please. Insurers selling these plans must include in their marketing materials a consumer disclosure notice as prescribed by the Federal Department of Health and Human Services. This notice should state, this coverage is not required to comply with certain federal marketplace requirements for health insurance, principally those contained in the Affordable Care Act. They also state to be sure to check your policy carefully to make sure you are aware of any exclusions or limitations regarding coverage of pre-existing conditions or health benefits. Your policy might also have a lifetime and or annual dollar limit on health benefits, and it also must state if this coverage expires or you lose eligibility for this coverage, you might have to wait until an open enrollment period to get other health insurance. Next slide, please. Unlike ACA regulated comprehensive coverage, short term plans may limit coverage based on an individual's prior health status and possible pre existing conditions. They may limit maximum annual dollar and lifetime dollar coverage and lack guaranteed renewability. Many plans also state that conditions that developed under the prior plan would be considered pre existing. They can also conduct post claims underwriting, which is where an insurer can review the consumer's prior medical history and determine there was a prior treatment or a diagnosis and use that information as a basis to deny a claim. They also have high deductibles, and short term health plans don't just limit the types of care they cover, they may also limit the amount they'll pay for the care they do cover. Next slide, please. So, moving on to healthcare sharing ministries. There are over 100 healthcare sharing ministries certified by the Federal Department of Health and Human Services as meeting the minimum criteria and requirements to meet the individual mandate under the ACA. The member is required to pay any medical bill first with certain health needs eligible to be posted in a newsletter for other members to donate funds to offset the individual's expenses. These were the original GoFundMe types of accounts. Next slide, please. Healthcare sharing ministries are non insurance entities in which members share a common set of ethical or religious beliefs and share medical expenses among members in accordance with those beliefs. In a healthcare sharing ministry, members contribute, typically on a monthly basis, a payment or share to cover the qualifying medical expenses of other members. The ministry will then either match paying members with those funds who need them for healthcare costs or pool all the monthly shares and administer payments to members directly. Next slide, please. Because healthcare sharing ministries are not required to comply with the ACA consumer protections, coverage for pre existing conditions may be limited or excluded. Medical benefits are typically far more limited than in an ACA compliant plan, and members are never guaranteed payment, even if it's for a covered service. They can cap out of pocket costs and are not required to cover essential health benefits. They can also set monthly, annual, and lifetime limits stated as caps on coverage. Lastly, they may charge a higher rate based on a health status, and some will even deny membership to those who can't pass a medical screen. Next slide, please. These are some of the items that we talked about yesterday, so I will again read through the definitions in general of them. Medicare is a broad program of health insurance designed to assist the nation's elderly to meet hospital, medical, and other health costs. Medicare is available to most individuals 65 years of age and older. The Employee Retirement Security Act of 1974, or ERISA, is a federal law that sets minimum standards for most voluntarily established retirement and health plans in private industry to provide protection for those individuals in these plans. The Consolidated Omnibus Budget Reconciliation Act, or COBRA, gives workers and their families who lose their health benefits the right to choose to continue group health benefits, provided their group health plan for a limited period of time under certain circumstances, such as a voluntary or involuntary job loss, reduction in the hours worked, transition between jobs, death, divorce, and other qualifying life events. Individuals may be required to pay the entire premium for coverage. The Mother's Health Protection Act, also known as the Newborns Act, includes important protections for mothers and their newborn children regarding the length of a hospital stay following childbirth. This requires group health plans that offer maternity coverage to pay for at least 48 hours of a hospital stay following childbirth or 98 hours in the hospital in case of a C-section. The Women's Health and Cancer Rights Act of 1998 is a federal law that provides protections to patients who choose to have breast reconstruction in connection with a mastectomy. This law applies generally to both persons covered under group health plans and persons with individual health insurance coverage. The Health Insurance Portability and Accountability Act, or HIPAA, was developed in 1996 and became part of the Social Security Act. It assured health insurance portability by eliminating job loss due to a pre-existing medical condition. It also reduced healthcare fraud and abuse, and it enforced standards for health information and guaranteed security and privacy of all health information. MAPIA prohibits group health plans that offer mental health benefits from imposing more restrictive annual or lifetime limits on spending for mental illness that are imposed on coverages of physical illnesses. The Patient Protection and Affordable Care Act was enacted to ensure that all Americans have access to quality health care coverage that is, and it eliminated the pre-existing clause that prohibited some consumers from being able to purchase a quality health care plan. Lastly, the Federal No Surprises Act was enacted effective for services received after January 1st, 2022. This protects a consumer from surprise bills for emergency services from an out-of-network provider or facility and without prior authorization, out-of-network cost sharing, like out-of-network coinsurance or copayments, for all emergency and some non-emergency services. It also provides protection of out-of-network charges and balance bills for supplemental care, like radiology or anesthesiology, by an out-of-network provider that works at an in-network facility. Next slide, please. The Federal Affordable Care Act, also known as the PPACA, Patient Protection and Affordable Care Act, was enacted in March 2010 and was the most significant change to health insurance since original Medicare was implemented.
5.
It
Addresses the quality of care.
the cost of care, accessibility, and gaps in insurance coverage. Some of the health insurance reforms began in 2010, and some of the reforms did not begin until 2014. Example of the reforms include prohibiting lifetime dollar limits and annual dollar limits on essential health benefits, also known as EHBs. It also required coverage of specific preventive services with no cost sharing. It guaranteed issuance of a health insurance policy and prohibited pre existing condition limitations. The ACA provided for the 2014 implementation of health insurance exchanges, also called health insurance marketplaces, a federal website that allows consumers to purchase qualified health plans and to determine their eligibility for federal premium tax credits and cost sharing subsidies. The federal government uses the health term marketplace instead of exchange. OCI continues to have regulatory authority over the insurance companies that offer coverage through the ACA. However, please note we do not have any authority over the marketplace themselves since they are a federal entity. Next slide, please. There is an interactive map on our website that can break down county by county which insurers offer plans in that coverage area. This also provides the plan type and whether it is marketed through the marketplace. No consumer who signs up for coverage can be refused or have coverage limitations placed, such as a pre-existing coverage clause on an ACA policy. There are 10 minimum essential health benefits required to be covered under the ACA. They are ambulatory patient services, emergency services, hospitalization, pregnancy, maternity, and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventive and wellness services in chronic disease management, and lastly, pediatric services that include oral and vision care. In 2024, the amounts listed on this slide are the most an individual or a family will have to pay out of their pockets for covered expenses under an ACA plan. Next slide, please. Under the healthcare law, insurance companies can only account for the 5 things listed there when setting premiums. However, states can limit how much these factors affect those premiums. The ACA provides that comprehensive individual and small group health plans be categorized into one of 4 different metal tiers. The tiers represent the average portion of expected costs a plan will cover for the average population. The percentages these plans will spend on average are 60% for bronze, 70% for silver, 80% for gold, and 90% for platinum. There is also a catastrophic health plan available through the ACA to eligible individuals who are under the age of 30 or who qualify for a hardship exemption. Bronze plans usually have the lowest monthly premiums, but the highest cost out of pocket when one gets care. This plan is often selected if one usually uses few medical services and wants protection from very high costs if they were to get seriously sick or injured. The platinum metal tier usually has the highest monthly premiums, but the lowest costs when receiving that care. Next slide, please. The open enrollment is the period of time when changes and updates can be made to an ACA plan for the upcoming year. For example, a plan sold or amended during the open enrollment period this year would have an effective date of January 1st, 2024 if completed by December 15th, 2023. And now at this time, I'll hand it over to Amy.
Good morning. Yes, this is Amy from the Office of the Commissioner of Insurance. Uh, An special enrollment period, or SEP, is a time outside of the yearly open enrollment period when you can sign up for health insurance. A consumer may qualify for a special enrollment period if they've had a certain life event, including losing health coverage, moving, getting married, having a baby, or adopting a child. Depending on the special enrollment period type, a consumer may have 60 days before or 60 days following the qualified event to enroll in a plan. Some examples include losing existing health coverage, including job based individual and student plans, turning 26 and losing coverage through a parent's plan, getting married or divorced, having a baby or adopting a child, death in the family, moving to a different zip code, county, or a student moving to or from the place they attend school. Here is our first polling question of today. You have around 30 seconds to make your selection. Special enrollment periods or SEPs allow individuals to enroll in an ACA outside of the normal enrollment period when that person, please make the appropriate selection, please. We have about 10 more seconds. Yes, everyone got that correct. The answer is C, loses eligibility for Medicaid. The state of Wisconsin continues to offer a highly competitive market for consumers looking at the exchange. We also require an insurer to offer the same plans off exchange in the individual market as well. The interactive map on our website allows you or a consumer to narrow the available plans down to the county the consumer lives in. It lists what type of plan, like an HMO or POS, that the plan is, a contact phone number for that plan, and it will also link you directly to that company's website. Under the Affordable Care Act, health insurance companies cannot refuse coverage or charge you more just because you have a pre existing condition. That is a health problem you had before the date the new health coverage starts. However, policies not subject to the ACA, such as short term limited duration or fixed indemnity policies, may continue to have pre existing condition limitations. A health insurance company may use different criteria or definitions from what a healthcare provider may use, and obtaining the medical records is a company's way of determining whether a condition was pre existing or not. If a consumer or provider disagrees with an insurer's determination, they have the right to appeal through a grievance. All insurers that insure health benefit plans must develop an internal grievance procedure. Insurers are required to file with OCI an annual grievance report to show how many they have handled during that previous year. The independent review process provides an insured with an opportunity to have medical professionals who have no connection to their health plan review a dispute. The IRO has the authority to determine whether the treatment should be covered by the health plan. The definition of medical necessity is not in Wisconsin law or statute, as it's defined by the insurance company, and the company's opinion of necessity can differ from a provider's opinion. Thus, the reason that the grievance and IRO procedures were developed. Examiners at OCI do not make medical determinations as we are not medical professionals. For example, some of the most common complaints we see are differing opinions between companies and providers on the number of sessions necessary for physical therapy or if a surgical procedure is necessary. The payment of a claim is not overdue until 30 days after the insurer receives the proof of loss required under the policy or equivalent evidence. Also, a delay in payment must be justified if the insurer cannot determine to whom the claim should be paid to. The date of payment is not the date a check or payment was properly mailed, or, if not mailed, the date of delivery of the payment. This does not apply to self-funded, Medicare Advantage, or Medicaid plans, along with those providers that have provider agreements with the company. Here is our second polling question of today. You will have around 30 seconds to make your selection. Which of the following is true? Please make the appropriate selection. Just one moment, please. It looks like we may be having trouble with our polling option. So the appropriate answer is B for all of those who cannot make the selection. We will go on to our next slide. In any state, there can be challenges geographically to ensure there are adequate number of providers for a plan's number of enrollees. We have received complaints in the past concerning the number of providers within an area. Wisconsin statute does not define how many providers must be located within a certain mile radius. In a lot of these cases, we ask companies to work with their members to find providers that fit their needs or work with them to possibly approve seeing someone outside of their network if a provider cannot be found. All ACA compliant plans must have embedded out of pocket maximums. All family deductibles must be no more than double the individual deductible rate under the ACA. For example, if the individual deductible is $3,000, the family deductible can be no more than $6,000. This measure, too, is an effort to alleviate the financial stress on smaller families. This can be confusing. Make sure to check the policy and ask questions. It is important to understand and explain how and what accumulates toward the deductible and out of pocket maximum. There are two types of deductibles, but the difference matters only for plans covering more than one individual. The difference has to do with the amount an individual or a family must reach before the insurance company begins paying for expenses. Embedded deductible means if a family member meets their individual deductible before the family deductible has been reached, their services will be paid for the rest of the policy term, which helps to relieve financial stress on smaller families. And it will be paid per the policy as it's defined. There could be cost sharing and copays. In the case of non-embedded deductible, the total family deductible amount must be met before any family member services would be covered for the remainder of the policy term. This amount could be applied to one individual or across all members of the family. For a consumer to fully understand the cost of their health insurance plan, you must start with the premiums and then add cost sharing. Remember, the amount of out of pocket may exceed the stated out of pocket maximum if a copayment does not contribute towards meeting the out of pocket maximum. This must be defined in the policy language. For example, a specialist visit copay of $50 may not go towards the maximum out of pocket. It's very important for a consumer to understand that possibility. The next few slides show a sample found on the healthcare.gov website of the summary of benefits a company is to provide to its members. This is a snapshot of the health plan's costs, benefits, covered healthcare services, and other features that are important to consumers. Summary of benefits also explain health plans' unique features like cost sharing rules and include significant limits and exceptions to coverage in easy to understand terms. This is the first page, which provides deductible and out of pocket information. Here is the second page of our example, which outlines information related to common medical services received. It defines the member's cost for in-network and out-of-network providers. In this example, on page 3, it provides some information on what types of services are excluded and covered under the policy. Page 4 provides cost sharing examples for medical services received under the plan to provide the consumer an overall picture of how cost sharing applies for services. Wisconsin's mandate applies to all group health plans policies covering hospital care with an exception for groups less than 10. Mandates beginning with 632.895 subsection 9 of the Wisconsin statutes, coverage of drugs for the treatment of HIV, applied to self-insured by a county board, by a city or village, by a local government unit or technical college district, by a town or by a school district. Some self-insured plans and government units use third-party administrators to administer their plans and pay their claims. Group health insurance policies and self-funded state and local government health plans must provide coverage for mental disorders, alcoholism, and other diseases. This includes inpatient, outpatient, and transitional treatment for alcoholism, drug abuse, and mental and nervous disorders to ensure that the financial requirements and treatment limitations on mental health or substance use disorder benefits are no more restrictive than those restrictions on medical or surgical benefits. Group health policies are required to provide coverage for transitional mental health, alcohol, and other drug abuse treatment arrangements such as day hospitalization. HMOs, in addition to covering the mental health services described above, are required to provide certain benefits for outpatient treatment of nervous and mental disorders, alcoholism, and other drug abuse to a dependent student who is attending a school of higher education located in this state but outside the HMO service area, if the HMO would have provided benefits for such services by a selected provider within the service area. Preventive care services are not subject to cost sharing when delivered by doctors in the insurance network. Depending on the date and depending on the policy, COVID-19 immunizations are a preventive care service. High deductible plans, first dollar coverage is often available for certain preventive care benefits, such as an annual physical. Refer to the list of preventive services on the healthcare.gov or U.S. Preventive Services Task Force at the below web address. COBRA is the federal law allowing most employees, spouses, and their dependents who lose their health coverage under an employer's group health plan to continue coverage at their own expense for a period of time. COBRA applies to insured health plans and self-funded employer-sponsored plans in the private sector and those plans sponsored by state and local governments, and applies to employers that have 20 or more employees. Wisconsin's continuation law applies to most group health insurance policies providing hospital or medical coverage. The law applies to group policies issued to employers of any size. Additionally, employees who live outside of the state of Wisconsin during employment with an employer located within Wisconsin would be eligible for continuation coverage. The law does not apply to an employer's self-funded health plans or policies covering only specific diseases or accidental injuries. When both laws apply to group coverage, it is the opinion of our office where the federal and state laws differ. The law that is most favorable to the insured should apply. Separation from the employer cannot be for gross misconduct. The individual continuing insurance must pay 100% of the premium. You may be asked, am I eligible for a special enrollment period under the ACA if I decide to drop my continuation coverage or stop paying premiums during the 18-month eligibility period? The answer would be no. You are not eligible for an SEP or a special enrollment period if you voluntarily cancel your continuation coverage before your 18 months of eligibility have been exhausted and you are outside of the annual open enrollment period for health insurance. It is the responsibility of the employer to notify the enrollee of their continuation rights, not the insurance company. And that concludes our presentation so far this morning.
It looks like we're having a little bit of trouble with our live Q&A right now. So I am going to just check back with our technical assistants to see if we can get that going to do the Q&A for the end of this session. So if you guys can just bear with us 1 second. All right, so it looks like as a workaround, what we will do is if there are questions, can you go ahead and put them in live support? And our conference technology services will help us get to those questions. They'll let the presenters know. So any questions, please go ahead and put them in live support. All right, there may be a question here. Will we get copies of the presentations is the question. Yes, you absolutely will. We will have those at the end. We can get those out to everyone. Any other questions, we can go ahead and put them in the live support. All right, looks like we have a question for Health Insurance 101. For medical necessity, does the insurance company usually have some kind of medical team review the request, or is it based on opinion of the agent reviewing it?
Within the OCI, or I mean, OCI has no opinion on medical necessity. Insurance companies perform their own review, and that can vary by the company of what that team or that review looks like. That is all determined by company.
Awesome, thank you. All right, we'll give a little more time for some questions. I think we'll go one more minute here for questions. At 10 o'clock, we will then sign off just a little bit early and we will work on the technical side of things before we rejoin together at 10:30. So we'll give just a little more time for any questions. All right. So we are going to go ahead and close out. We will see everyone at 10:30 for the second session. And hopefully we will get our little hiccups fixed. Thank you so much.